So good afternoon, everyone, and welcome. It's wonderful to have you here today. I'm going to introduce you all to Brian and then turn it over to him. I'll let you know a little bit about his background and expertise, and then really let him lead us on today's presentation. So Dr. Brian Flynn is the Associate Director of Health Systems in the Center for the Study of Traumatic Stress, CSTS. Also an adjunct professor in the Department of Psychiatry at the Uniformed Services University of Health Sciences. And really a major focus of his work is preparation for, response to, and recovery from the psychosocial aspects of large-scale emergencies and disasters. In addition, he provides the Center for the Study of Traumatic Stress leadership in the area of behavioral health policy and systems development and integration. He's recognized nationally and internationally for his expertise in large-scale trauma, working with many nations, and formerly as Rear Admiral or Assistant Surgeon General in the Public Health Service, he oversaw the federal government's domestic disaster mental health program, including terrorism, programs in suicide and youth violence prevention, child trauma, refugee mental health, women's and minority mental health, as well as rural mental health. And today he will talk about the history of CSTS, including their broad scope of activities. The center works in an extensive range of situations, including violence, disasters, war, accidents, and other forms of community trauma. It focuses on how a wide range of individuals, families, and communities impacted by trauma events and how they can be best served to promote community healing and resilience. So without further ado, I'm going to turn it over to Brian. Welcome, Brian. Thank you.
Thank you. I really appreciate the opportunity to join with you today. It's always a thrill for me when I can do anything related to NASMHPD. As you will hear, I've had a long history with the organization, and it's one of my favorite things to do is to work with anything sponsored and supported by NASMHPD. So, it really is it's a wonderful, exciting opportunity for me to get back to doing things with the state. So that's why I'm glad to be here. The other thing is the relationship between the Center for Studies of Traumatic Stress and NASMHPD has been about a 20-year relationship. Before I came to the center, it had no relationship with NASMHPD or the states. And that was, I think, one of my value-added features that I was able to bring to the center. And we have had, since that time, a very close working relationship with NASMHPD. It's been primarily around disasters. Blow this up so I can see my slides a little better. In recent years, we have strengthened our relationship with our medical resources and the state's mental health authorities' medical resources, primarily with the addition of Dr. Joshua Morgenstein, who's both a psychiatrist and family physician and has a passion for disaster-related issues. So he has really helped foster that part of the relationship. And we have had both organized and ad hoc consultations with the state through NASMHPD. There are times when states will contact us directly, but probably more often than not, we'll get a call from Brian Hepburn or somebody at NASMHPD saying, would you be willing to talk to state X about this? And they'll make that entree and we'll do that consultation. So I wanted to just let you know that there's been a long history between our two organizations. Next slide. Okay, before I start talking about the university, what I want to talk about just for a couple of minutes is kind of at least my expectation of what might come out of this meeting today. We have a big organization and a complex organization that's doing a lot of things, and that's what you're going to hear about today. Candidly, there's probably a lot of that may not be directly relevant to the needs that you have in the States. But I'm willing to bet that there are some things in what we do and who we are that can be very helpful to you, that you will find immediate relationships between what your interests and needs are and what we do. I think you'll also find things that can be adapted or that we can help you take some of the things that we've developed and adapt them to your needs. I was thinking in the preparation, is I like metaphors, and to me, it's kind of like we have a buffet, and you're standing in front of that buffet, and what you see in that buffet is everything we have to offer. Now, you may be hungry or you may not be very hungry, so you may have different levels of need or interest in what is in the buffet. The other thing is you may have an interest in one of the items in the buffet, but it's not quite to your liking. So basically, we can give you the recipe for that and help you cook that in your situation. So I think there will be things that will be of interest and a match. I think there are things that are not, but this meeting will be a success, at least for me, if at the end of it, you know what we do, you can begin to develop some ideas about what might be of interest or service to the missions that you have. And there may well be things that I haven't thought about that we can hear about from your end. So this is a get acquainted meeting. Also, because of the diversity that you'll see in what we do, I can't answer all the questions that you might have, and especially in detail about some of the activities that we're involved in. I am primarily involved programmatically in disaster-related kinds of things. I am acquainted with the other programs, but I can't answer the second level questions, but I can get you the right people who do. So I want people to know that while I have a thin patina of expertise in all of the areas that I'll talk about, I'm not the content expert in most of them. So let me just begin by telling you who we are as a university. The Uniformed Services University of the Health Sciences is part of the Department of Defense. It was started about 50 years ago, and it's the nation's health professions academy. In lots of ways, it's like a service academy, like West Point or the Naval Academy, but this is for health professionals. All of the students that come to the university are in one of the uniformed services, Army, Navy, Air Force, Marines, Public Health Service, and this year we have our first Coast Guard student. So they are all commissioned as ensigns when they come in. Some come in from civilian life, just finishing college. Some are already in the military. Some come from the military in very different occupations. Some may have been medics. I met one of our students the other day who is a former Navy SEAL, who is now a medical student. So what the university does is it commissions everybody as entry-level officer, provides for the School of Medicine a medical education with a service responsibility after that. And after they finish medical school at USIS, then they'll go on most everybody to residency programs where they get further training and incur further obligations. So typically, by the time somebody finishes this, they've got 15, 16 years of service and obligation. And so because of the military's 20-year retirement program, we usually have people through a 20-year career. So just structurally, inside the university as a whole, there's the School of Medicine where I am. I can't really talk much about the other schools because I don't have much involvement with them. We're in the Department of Psychiatry there. The Department of Psychiatry has about 150 faculty totally, not just at the main university site, but others, and then the Center for Studies of Traumatic Stress. And we have, depending on how you want to count it, probably 40 to 50 people in that. Next slide, please. So the history of CSTS, we were established in 1987, really to examine the psychological and behavioral effects of use and threat of weapons of mass destruction. You can see as part of the Department of Defense why that might be a primary interest at that point. But we grew dramatically in terms of the scope of what we do. We look at trauma in the context of all kinds of disasters. And Bob Ursano, who is our longtime director, is fond of saying that war is just another kind of disaster. The notion of disaster is the overarching concept of everything we do, whether it be human generated or natural disasters. Next slide. So this is a graphic representation we've been using recently to kind of show kind of where everything fits together. So if you look at about 8 o'clock, you'll see what I just talked about in terms of the structure. If you go up clockwise, we're interested in providing leadership, scholarship, service, outreach, readiness, intervention. The main focus that we have is military service members, their children, their families, and military communities and civilians working within that structure. Again, I don't want people to think that the military is all we're interested in, because we aren't. We do a lot of activities you'll hear about beyond that, but since we are part of the Department of Defense, that is always a primary mission of ours. We get involved in all kinds of activities, from disaster response to neurobiology and neurosciences that I'll talk about. We have clinical labs. We're involved in lots of global health and mental health activities also. We disseminate what we do through a wide variety of mechanisms, different partnerships that I'll talk about, conferences, presentations, publications, textbooks, etc. And as I mentioned, we're involved in all kinds of trauma, war, terrorism, disasters, community violence, public health threats, certainly, as we have seen in COVID. We have bench science. We pride ourselves in being involved in behavioral health issues all the way from the cellular level to the policy level. And we do that through research, education, and training, consultation, and collaboration. And I'll talk in detail about those next. Next slide, please. So in research, as I said, we do everything from cellular research to, I didn't know this until recently, but apparently zebrafish create great animal modeling for some brain research. And so we have a colony of zebrafish that we use. So we do bench research, medical psychiatric consequences of war, issues of deployment, and that is a big issue for us. What happens with people psychologically, psychiatrically during deployment, after deployment, trauma, disaster, terrorism. We do education to our students, to members of other organizations on consequences of trauma, terrorism, disaster, and war. We can conduct training in a variety of areas. Consultation is probably the area that I'm most involved with, and we consult to a wide variety of individuals and organizations, other governments, other government agencies, organizations like NASMHPD, other universities, etc., on all kinds of issues, including medical care to trauma victims, families, and communities. And then one of the things that you might be most interested in all this is some of our knowledge products. We take very seriously dissemination of what we think we know, what we learn, and helping try to make that applicable to other kinds of situations, to the needs of other organizations. And we do that to a very wide variety of knowledge products that I'll talk about. Next slide.
And Brian, right here, we're just going to do a quick poll for the audience, and I'll go ahead and read the question. It says, to what extent is your department involved in issues of military service members or veterans and their families, issues with military bases, etc.? And the options are not at all involved yet, starting to be involved, reasonably involved, or very involved. And the second question, if this doesn't apply, you can say NA, which is the last option, but if so, in what capacity? So veteran-specific crisis hotlines, behavioral health collaboration with military bases, behavioral health community connections with service members and veterans. And the last option, you can feel free to specify in the chat if your answer is not on here.
Okay, well, this is a interesting dispersion here. So we got about 20% not involved at all, starting to be involved, reasonably involved, very involved. So that's almost it's a large proportion of folks that have some involvement. So that's good to hear. So again, I think for those populations, you will find the kinds of materials that we have very relevant and easily adaptable to a wide variety of needs. I also think there's probably ways to take some of the issues that are apropos to veterans and apply them to other kinds of situations, military rather than veterans. You know, there are clear differences, but military structures and military experience is somewhat similar to law enforcement. When we talk to and about law enforcement issues of stress, there's quite a amount of overlap with the military experience. So your interest challenges may be more with law enforcement issues. So there may be things that you can adapt from what we do. So thanks. Why don't we move on? We'll go to the next slide. I wanted to give you just a smattering of ideas of some of the research projects that we're involved in. Again, this may not be of direct interest to you, but it'll give you a sense of the kinds of things that we're involved with. The biggest research study that we have ever been involved with is Army STARS, and that's Army study to assess the risk and resilience of service members. That started off as Army STARS, now it's STARS LS, means longitudinal study. And I'm going to tell you more about that. We do research in the area of Guard and Reserve. As you know, that has a lot of the characteristics of the regular military, except these folks live in your states when they're not on duty. And so they bring with them back home from their Guard and Reserve active duty experiences some of the traumas and issues that get visited in your systems, often more than ours. They don't come home to a base such most times. They come back to the communities in your states. Military mortuary affairs longitudinal study. We have for years had projects involving military mortuary affairs workers. I did some research not long ago with this group, and without getting into too much detail on that, if you think you had a hard day at the office, you can imagine what it's like to be a military mortuary affairs worker downrange, back here, dealing with remains, dealing with families, etc. These are amazing, wonderful people who often pay quite a price for what they do. We have something called a daily diary study. You know, we know a lot about PTSD in terms of its general up and downs, but there has never been any study of what does PTSD look like from hour to hour during the day. So we have a study that's been going for quite a while, where we give people iPads and they are prompted several times a day to give responses to a number of questions, so we can get a bit of a idea about, you know, what are the environments, what are the times and days that people are feeling more or less symptomatic in terms of PTSD. We're doing some fairly new research in nightmare deconstruction and using that as a theoretical, as a intervention model. We're doing some work with teams of workers, for example, mortuary affairs workers that go out when they come back from deployment, some training of those, workshops for them about reentry from those kinds of situations. And then rage control is a huge issue in terms of preventing violence and dealing with stress. And so we're doing some app-based biofeedback experiments in that. So this is just a smattering of the kinds of wide variety of research we do. Next slide. This is the Army STARS that I was mentioning again. It began in 2009, and it is the longest longitudinal study ever conducted in suicide. And it's producing a lot of amazing information. Right now, it's funded to run through 2025. It's our hope and anticipation that it will continue long after that. This is being viewed and talked about as the Framingham study of suicide. You may be aware that the Framingham study from Massachusetts is it's a study of heart disease that's been going on for decades. There's really nothing like it in the area of heart disease. We hope this develops into that for the area of suicide. And basically, it's a multi-university collaboration with us, University of California at San Diego, Harvard Medical School, and the University of Michigan. When we do research that is not funded exclusively by the Department of Defense, we often partner with other universities since it's kind of hard for us as a part of the government, basically, to apply independently for grant funding. So we often collaborate with others. Next slide. And again, this, I just want you to get the gestalt of this. The STARS and STARS LS is like a constellation of other smaller studies. And they're just listed here. You don't need to know about them. I don't need to tell you about them, mainly because I can't. I don't know that level of detail, but I want you to appreciate how much information is coming out of this study. And you will find on our website, references to everything that we're learning that's being published about that. We also have a situation now where we are allowing other universities to use the data to do further analysis. So this is a knowledge-rich activity, and it's one that we hope we're going to be able to support for a number of years. Next slide. Our child and family program, I think, is one of our most, I was going to say one of our most important. In my view, it's all important. When you have a military, that military member does not exist in a vacuum. He or she lives in a community, and they often have children and spouses. And so paying attention to their needs and their issues and responding to the challenges that they have is a huge part of our interest. So Dr. Stephen Koza, a child psychiatrist, is the head of that program. He's a retired Army child psychiatrist who was also the head of psychiatry at Walter Reed before retiring and coming to us. So again, just a few examples. We've studied deployment family stress, particularly child abuse and maltreatment and neglect in Army families. We have done a number of studies about combat injured families, where the military member comes back wounded, and studying how that impacts family life for that soldier, and how that family and that soldier can be assisted. We've more recently gone into studies of bereavement related to terrorism. We, as I said, talk about military-related risks for kids for child maltreatment, not just the epidemiology of maltreatment, but what are some risk characteristics. And we also are part of the ongoing study of World Trade Center impacts on families also. Next slide. This one, again, is just one I'm going to put up here and not explain. We have clinical neuroscience programs and neurobiology. That's not my area of expertise, so I can't tell you about what most of these are. I will tell you, I think one of the things that is most exciting and most unique is we are a partner in the National PTSD Brain Bank. We have a brain bank of PTSD brains. And we have an agreement with a number of veterans' homes to have people, while they were alive, make arrangements or with their survivors when they die to donate their brains for research. It's a unique activity, and I think so we're learning so much now about the brain that really didn't know even 20, 25 years ago, that this is going to be an increasingly important part of what we do. We're also looking a lot at sleep and PTSD genetics. And as I mentioned, we do a lot of work with animal models in the neurological and biological arenas. Next slide.
And we just have our another poll question up. And so the last one was about veteran services. This one is about disaster response services. So does your department have or work with any disaster response programs, i.e. community violence, school-based programs, environmental disasters, COVID, etc.? And this one is a short answer, so just feel free to write a couple words or a sentence or two.
100% yes. So maybe in the interest of time, we won't drill down further, but it would be curious to see which of those kinds of disasters you are most involved with. Again, my involvement with state mental health authorities has been primarily around in recent years around disaster related issues. As I'm sure you know, every state has an emergency coordinator. I used to, when I was at SAMHSA, work quite closely with all of them. Most of those have changed since I left SAMHSA, but the other reality of that is most all of those people have other jobs. This isn't a full-time job. So I think one of the things that I was curious about is the extent to which some of you may be either those people or relate with those within the Department within the Mental Health Authority. So I thought I might just take a couple of minutes and give you an example of the kinds of things that we've done in disasters. And I've covered a long period of time in this, but each of them is a little bit different in terms of what we do. It's about 20 years ago. There was a DC sniper situation in the Washington area where someone was apparently just kind of randomly shooting people, and it left the whole Washington, Maryland, Virginia area was living in fear of driving on the Beltway or going to get gas. These shootings occurred in an apparently random kind of way and really terrorized an entire metropolitan region. We did a study, actually two studies, partially funded by SAMHSA, to take a look at feelings of vulnerability in different locations, who felt what kinds of fear and anxiety, and what did some of the characteristics of these people, what was the extent to which if you were a male or a female, or if you were young or if you were old, or if you had experience with violence before, what were the factors that might influence how you reacted, and then took a look at what people did and to deal with that. And we've published several studies on that. The other study that we did that I think to this day is unique is nobody had taken a look at what a situation like that does to homeless people. And so we partnered with the School of Social Work at Catholic University and did some surveys of homeless people in Washington, D.C. Area to try to learn, what was their experience and how they're so vulnerable in the best of times. How did this kind of incident impact their lives? So then in 2004, we collaborated with CDC to do a study in Florida. During that year, there were 4 hurricanes that essentially had very similar tracks as they moved across Florida. And so the same people got impacted over and over again, and the same healthcare workers wound up doing repeated deployments and having to deal with these hurricanes. So we did a study of nurses in the public health system in Florida, and took a look at things like dose responses. Was there difference if they were occupationally impacted as well as their personal lives, et cetera? And we're actually still analyzing that data. That's a very rich environment. Some of you may remember about 10 years ago in Washington, there was a shooting at the Washington Navy Yard. And I included this because it provides an example of one situation that resulted in touching every part of the kinds of things that we do. In this situation, a contract employee came in and killed 13 people, I think it was, injured a few more inside the Washington Navy Yard. And right after that, two of our military psychiatrists were asked to come and consult with the leadership about what should they provide in there for the people. And they did a very quick consultation that was not publicized. This was to the base commander. But it's an example of kind of a real-time, quick, get in, help do an assessment, do a consultation, and then step back until we were asked to do something else. At the same time, I was in touch with the emergency coordinator in the DC Department of Mental Health, who was trying to deal with this disaster in the DC community. Again, one of the challenges in dealing with the Navy or any military base is they exist in communities most of the times, but they're very separate. And those walls, those gates don't open very easily or very often. So I was on a daily call with the emergency coordinator in the DC Department of Mental Health, along with another number of people consulting on what they might be doing in the community to deal with this. I also had private consultations with him outside those meetings. One of the things that I frankly enjoy doing very much, and at least I think is important, is, leaders are under tremendous stresses in these situations. And when I was working in disasters in the field, it was always very helpful for me to be able to have confidential contact with somebody who had been in situations like this before, and I could talk to candidly, and it wasn't going to go anywhere beyond that. So I provided those kinds of consultations. I've done that often. It's the kind of thing that'll probably never gotten written up, because I won't talk about the details of those, but providing that kind of off the record consultation in a crisis to leadership is something that I and a number of us as the centers do. We also did an interesting study there. The National Institute of Justice gave a grant to UCLA to study 7 different kinds of mass shootings in the country, everywhere from church shootings to mall shootings to theater shootings. And they wanted to include the Washington Navy Yard since it was so unique. So they funded us under that grant to go in and do a very extensive study on what happened to people there, what kinds of services did they need, what kind did they get. We talked to workers, we talked to families. It's some of the devil is in the details in a lot of these. In that situation, you had people in 3 different personnel systems. You had military members, you had civil servants, and you had contractors. So when it came to mental health services afterwards, there were 3 different systems that the people were eligible for, and kind of never the twain shall meet. So we conducted that study that's still being analyzed along with the other ones. And then we ended up our involvement with that study with I was the lead writer on an article that we did on doing research about and on military facilities. It's very different than any other kinds of research. So if you're interested in kind of how the culture of the military impacts the needs for research, I think that was there's a small audience for that, but I think it's an interesting one. And then certainly, new to us and everybody else was COVID and all that meant. It certainly was almost all other disasters are defined and confined by time and geography. It happens at a certain place at a certain time. COVID didn't do that. It happened everywhere for an extended period of time. So it really caused us to rethink, and it has created a number of new publications and documents that we have. So just wanted to give you a smattering of the kinds of disasters that we have been involved with. Next slide, please. Some of the disaster linkages that we've had, we've stayed connected with NASHPD through leadership change and the directorship. A number of years ago, I used to regularly be part of the new commissioner training. A lot of the new commissioners who didn't come through the public mental health system didn't have any idea what their responsibilities were in terms of disasters. So that was always an interesting part of that. We have presented at NASHPD meetings. Dr. Morgenstein did one on climate change just recently. And every time we produce a new document or new materials, NASHPD is a major partner in getting that disseminated to all the states. During COVID, we just had a lot of informal conversations thinking through all of this together. What's it mean for the mental health of the country, for the public mental health system, et cetera. So we had just a lot of informal conversations about that. Dr. Morgenstein and I did a number of national presentations to the commissioners and the medical directors. During COVID, NASHPD really helped foster our relationship with the International Initiative on Mental Health Leadership. And then NASHPD actually chaired for a while a regular quasi-formal meeting between Health and Human Services, us, and a couple of other major federal players, just to get together and talk about what kinds of problems were we having and what did we see as the challenges coming ahead. So NASHPD really facilitated that for all of us. And then Dr. Morgenstein just completed an article for NASHPD. So we've got a strong and long history. Next slide. Some of the examples of some of the state emergency and disaster consultations we've done, thought might be interesting. We've done informal and unpublicized consultations following school shootings. Again, request a mental health authority asked NASHPD, who asked us to talk with them about what can be done in a highly politicized environment. Again, these are the things that will never get written up, but I think they're probably very important to be able to call up somebody and just think through these kind of challenges that are really hard to talk about publicly. We were asked by one of the mental health authorities, I won't name the state, to talk about the potential psychosocial community impacts of bird flu. Bird flu doesn't directly, at least at this point, impact individuals, humans, but it does impact economies in rural areas that have a lot of poultry and other kinds of things. So they asked us to help think through what the impact on the mental health of those communities might be and to help make some recommendations. One state was interested in petitioning its legislature for enhanced support for disaster, emergency, civil unrest preparedness and response, and asked us to consult on, how could that best be presented to increase its probability of having legislative success. So again, it was for a different purpose, but it involved calling on a lot of our experiences. I went and facilitated in another state a multi-day meeting on disaster preparedness. The state was very interested, had a lot of disasters, was very interested in kind of rethinking their whole approach to it. So I was able to go out and assist in that. And another one, I will name the state, and this one, it was Missouri. This was one of the strangest, but actually most interesting little consultations that we did. The Missouri Department of Mental Health contacted me and said, "Can you help us think through a problem that we think we're about to have?" And this was when there was a lot of flooding on the Mississippi. And the Mississippi was about to overflow its banks. And the high risk was the inundation of Cairo, Illinois. That would have, had this occurred, would have destroyed much of that community. So what the Army Corps of Engineers planned to do was to detonate the levee that contained the Mississippi on the Missouri side, not the Illinois side, on the Missouri side, so that the water ran out and dispersed and did not overflow the levee at Cairo. Well, as you might imagine, Missouri wasn't that happy about this potential. And they brought suit against the Army Corps of Engineers to prevent this from happening. But that wasn't what they called us about. They said we have a 5 days notice before this is about to happen. So they had a very extensive planning activity going on in Missouri. And one of them involved the anticipation that this breach was going to inundate 15 cemeteries. And they weren't quite sure what was going to happen with these cemeteries, but there were 15 cemeteries in the area that was going to be inundated by this flooding. And again, without getting into more detail than anybody needs, flooding isn't good for cemeteries. And depending on how fast the water moves and how long it stays there, it has very different kinds of impacts on cemeteries. Some of these were cemeteries that were old, unused Civil War cemeteries, and most of them were active. So we pulled together a thought group in the center and provided an extensive set of recommendations about what to do in anticipation of this, to deal with worker stress issues, community stress issues, technical issues, and we're able to provide that to them. We actually had a little pushback on our end of that because the Department of Defense was afraid that we were going to be used against the Army Corps of Engineers here. We were able to assure them that we had nothing to do with that. This had nothing to do with their plans one way or the other. This was consequence management, and so we were allowed to do it. So again, I just wanted to show you the kind of consultation that we have done in the past. Next slide, please. Consultations and collaborations. This is a picture of a poster that we have on the wall of our conference room that shows many of the different partners and collaborators we have, and you'll see NASHPD down there, kind of the middle of the bottom row. But we exercise these internationally. We provide epidemiological consultations, global health activities, and we have multilateral arrangements with many of these organizations. So it includes NASHPD. Next. I wanted to again just kind of show you the scope. We were first involved in international consultation during the Armenian earthquake, and that was a long time ago. And we used NASA's Space Bridge actually to provide real-time consultation to the Armenians dealing with the earthquake. Again, now technically it's much easier. You don't have to use NASA and a space bridge, but the earthquake picture is on the upper row, and the bottom picture is from current conflicts and the current war that's going on now. We have ongoing consultation with psychiatrists in the war zone going on now with the current activities. Next slide. I wanted to just mention a couple of our newer ongoing programs that might be of interest to you. We recently got some unexpected funding to mount a suicide prevention program. Again, as you know, that is a big issue nationally. It's sure a big issue in the military. We don't have the time and the money to do research in that. So what we have done is we have hired a number of people to collaborate with the military and non-military communities to leverage existing programs and practices to develop a set of resources that are data informed and to look at hard to reach and at-risk populations. Next slide. Again, some of the things that are new in that, we have a series of podcasts. Let's talk about guns, you know, the suicide. More than half of the gun deaths in this country are related to suicide. So we have a series of podcasts that are up and running now. We have one on brain hijack that talks about how to bring science to practice, how to talk about complex psychological issues with different populations and multiple audiences. There's also, we've discovered as we've gotten into this, there are some very sensitive ethical issues in research on participants at risk of suicide. So we have provided some guidance on that. It's an exciting program. I'm not sure how long it's going to last, but we're putting out some very interesting materials on that. Next slide. We're always looking at different ways to get the word out. You know, typically we are a university. So as you'll see in the upcoming slides, we do books, book chapters, articles, but we also want to make sure that what we think we know is available easily to a lot of different audiences. And this is one of the most recent ones that just actually came out a couple of weeks ago. It looks a little odd on here, and that's because it's a pocket folding card. One of the things that we realized out there is for military leaders, if there has been a suspected suicide in their unit, there are plenty of guidances about what to do in that situation, but leaders are not going to go through an 80-page action document to see what to do. They need something that is quick and easy. So we developed this card that folds and goes in a pocket. So all a leader has to do is kind of pull this out, and he or she knows, has some guidance about what to do the first time that he or she has to talk about that. This is a great example of what you might be able to utilize. First of all, this has been sent out to all of our partners, including NASMHPD, for comment. Are there ways to improve this? This is written for the military, but one of the things that we encourage NASMHPD and everybody else to do is rewrite this thing to meet a non-military audience. One of the very nice things about all of our materials is that because we're in a government organization, everything we do is in the public domain. So you can take this and adapt it to anything you need. If you do that, we like some acknowledgement of where it came from, but even that's not necessary. So that's one of the things I want to leave you with, is all the things I'm going to talk about are yours for the taking, and you have our blessing. In fact, we consider it a great compliment if people take our materials and adapt it to their needs. Next. So we have education and training programs here. You're going to have to hit the button, I think, on that one. We haven't done most of these since COVID. We will be getting back to them. in the future. But again, you, as you know about these, increasingly are invited to them. If you have forums or symposia where we could be of help by participating in yours, we'd be glad to. Next slide. Okay, and another, this is again, I'm not going to go through all this, but it's an example of the kinds of events and training programs that we have conducted over the years. We have an annual amygdala conference. That's 90% of it is over my head because it's basic science most of the time, and that's kind of not my thing. But we have a number of educational programs. I guess I should have said all of these. The reason I'm going through it is all this material is on our website. And my strongest recommendation to all of you is to go to that website, see what we have now that I've given you an overview, and see what's relevant to you. Take it and use it, or talk to us about how it might apply to you and ways that we might help. Next one, please. We do articles, journal articles. Again, in the interest of time, I'm not going to over time as it is. I'm sorry. So let's just go through this. We have articles. Next slide. Chapters and books. Next slide. Books, again, all of these are referenced and can be found on the website. Next slide. We have different health campaigns. Again, there's another pocket folding one that we did on pandemic activities, select, train, assess, and reset. Again, just some quick guide when you have to do something quickly. Next slide. We have 2 newsletters about families and about research that come out quarterly that you may be interested in. Next slide. And some of our fact sheet, and I do want to pause for a second here because we have over 100 fact sheets. These are 1-page things that are written in understandable, usable language. They're available in many different languages. And again, this is probably one of the things that our partners use most often. They'll take a fact sheet, adapt it to their special need, and put their logo on it and make it theirs. But I strongly encourage you to use those and make them your own. Next slide. We also have a disaster behavioral health curriculum that I think is pretty amazing. If you're interested in doing anything from a 15-minute presentation on children and disasters to a semester-long graduate course on the same thing, in this document, what you can find is the basic resources for that. It's not a curriculum, but it is it gives you access to kind of vetted, legitimate citations to use in that. So it's a great tool for designing curriculum and at every level, different durations. Next. We have an online presence, Facebook, all of the other ones. That's not my thing, so, but we are there. You can follow us on that. Next slide. Let me just come back to this. If we can go to the next slide, then I want you to watch out for our manual report that's coming out probably in a month or so. This is our website. Here is my email. And I'm not quite sure what we ought to do at this point. If we go back to the previous slide, I had raised another number of issues for us to talk about, but unfortunately my Irish DNA took over and I talked too much today. So
no worries at all, Brian. Thank you.
So we're
so
over
much.
time.
We encourage folks to get back to us with questions. We put it in the chat. So we just thank you for your time. We thank everyone for participating, and we wish you a great afternoon. Thanks so much. Take care. Bye-bye now.
Thank you.